Good evening. My name is Dr. James Greenblatt, and I want to welcome everyone to Module 1 of the ADHD course for health professionals. Get rid of the picture so we can see the slides, and we're going to talk a little bit about history, and I'm going to try to focus as much as I can on how to utilize integrative and orthomolecular practices in our clinical practice. Whenever we talk about ADHD, everybody has a theory, and now we're pretty comfortable blaming screens and junk food and the environment, and those all might have relevance we'll talk about. But I love this poem, Fidgety Phil. It's written by a German psychiatrist in 1846 about a hyperactive child at the dinner table. And then 100 years later, by accident, a psychiatrist in Rhode Island gave amphetamines to kids, and they improved tremendously. So this is not a new disorder, but I think the evolution of the name is really important. I just want to go over this briefly, but if you look from the 1900s up until DSM-5, the medical profession has changed the name. And there was in the 40s, after a influenza epidemic, they referred to these children as brain injured. And then in the 50s, I think they felt bad for these kids, so they were just minimally brain damaged. And then we did hyperactivity with or without. I think, the DSM-5 at this point, we do have the neurochemical, environmental, nutritional knowledge to begin to make sense of ADHD. It's part of the reason I wrote the book. And after treating this for almost 30 years, now trying to educate professionals. We have every other major psychiatric illness that is what we call comorbid, and it's really important as we understand what is going on as we treat ADHD, that we also understand the comorbid conditions. ADHD in children is the highest of all neuropsychiatric illnesses, 8 to 10% of all school-age children. And what is becoming much more evidence-based is the 40 to 60% of these cases continuing into adulthood. Part of the reason I'm, again, trying to get the word out about integrative and nutritional therapies is the use of medication is skyrocketing, increasing dramatically. The American Academy of Pediatrics, it decreased the approval for amphetamines from age 6 now to age 4. And we saw a child in the office today, a 4-year-old taking 2 medications for ADHD, an amphetamine and a non-amphetamine medication. One of the most important points I can make tonight is that I'm confident for our kids under 6, many under 12, that oftentimes we can avoid the use of medications if we understand what's going on. Some just key factors that I think we're all aware of, but just to reframe the terms that I like to think of and talk to families about, ADHD is a performance disorder. It's not skill-based. It's not about intelligence. So the symptoms are only evident when there's an execution of behaviors, when you're asking the child to read or asking the adult to pay attention in a meeting. Somebody is not going to notice ADHD by looking at them. And then the one-word diagnosis for ADHD is asking the adult, asking the child, asking the adolescent about boredom. They'll tell you before you have even time. And I think it is a very powerful kind of overarching symptom that has a neurochemical basis, and it is very, very simple and easy to, certainly for our patients and parents to understand. We're all familiar with the concept of biochemical individuality, but it's really a core concept through all of the ADHD modules. We can have 10 children the same age with the same symptoms, and we're looking for the underlying cause. Each module will be focusing on a few of the more common biochemical causes, but everyone's different. I see this kind of symptom-based treatment, certainly common in our medical colleagues where amphetamines and drugs are the only intervention, but it's just as common now in our kind of functional medicine, naturopathic crew, where we are recommending a supplement to a patient or to a family without necessarily looking at the uniqueness of that individual's biochemistry. So when we think about what causes ADHD, again, the science is quite significant. We understand genetics, we understand the environment, and I will focus on some of the dietary pathways that disrupt neurotransmitter synthesis as well as GI function. So we won't spend details, but genetics, 50% of kids have a parent with ADHD, whether they're diagnosed or not, and estimates of genetic variation accounting for about 75% of the kids that we're treating. The genes are not one, many, controlling synthesis of neurotransmitters, receptors, enzymes that are related to attention, focus, and this concept of reward. The environmental causes are quite well documented now, more prevalent in kids who live in the city. Poorer kids are twice they like to have ADHD, maternal exposure, pesticide exposure, migrant workers, farm workers, all have much, much higher incidence of ADHD. And then in some of our environmental toxins, BPA, this is a new study, 2016, 460 children, kids with higher levels of BPA, 5 times greater odds of being diagnosed with ADHD. As I said, nutrition often overlooked, certainly by our pediatric colleagues, and that's what I will focus on. Part of what my message is to clinicians or to parents is trying to understand that ADHD is a neurochemical biological phenomenon. Our children, our spouses, our family members are not displaying the symptoms of inattention and overactivity and impulsivity to irritate us, and they're displaying them because they have poor neurochemical regulation. My message is always, since these are neurobiological illnesses, we need neurobiological interventions. Nutrition is one. Untreated is what I just want to talk about now. Debilitating, and I can't overestimate the concept of debilitating lifelong symptoms of not treating ADHD. Think of early assault to self-esteem, academic achievement, occupational performance, job, relationships, associations with binge eating and obesity, sexual behavior, criminal relationships, criminal behavior, and I mentioned divorce. Some of these I'll go through quickly. Untreated ADHD in kids, 50% suspended from school. Treatment leads to better school performance. In adolescents, 30% fail to complete high school, 3 to 4 times the rate of substance abuse disorder. Really important because parents are very concerned about treating with medications. And my approach is I try to look at nutritional interventions, but you need to treat the ADHD. Medicated kids continue to have lower rates of substance abuse than untreated. And then this is just profound. The research is quite significant and has been repeated. Car accidents, this is for adolescents, but we have the same data for adults. Speeding tickets, traffic violations. Here, the risk of totaling the car exceeds that of a legally drunk adult. Okay, enough. We need to treat ADHD. How can we treat it? One of the reasons that I wanted to put this information into the book, Finally Focused, is because there was a model that seemed to kind of make sense. How do we take this biochemical individual model? How do we help clinicians or parents? And I divided it into things that needed to be added and things that needed to be avoided. And tonight we're going to talk about some of them, and then throughout the courses we'll get to details. Tonight we're going to talk about the gut and probiotics, environmental toxin, allergies, and a little about celiac disease. But if you see here, this plus-minus approach, there are individuals where things are deficient. So vitamin, mineral deficiencies, hormones, acid, talked about probiotics, phytochemicals we'll talk about. But we could add things like light, like physical affection, like self-positive reinforcements. And then what needs to be avoided, we could also add to this list, but we have allergies and environmental toxins, autoimmune disorders. So let's get started. I chose to start the seminar with the right food, maybe the wrong food, just because there's lots of confusion. And here we're going to talk about neuroactive peptides. We're going to talk about food allergies. We're going to talk about celiac disease. And many, both therapists, clinicians, doctors get confused on the many different ways that someone could be sensitive to food. Here I just took dairy and wheat. You can have celiac disease and non-celiac gluten sensitivity, and then so much confusion with lactose intolerance. I was tested for lactose, so dairy should be fine. And then for both these foods and others, we can have delayed hypersensitivity, IgG, IgE. We're going to talk about DPP4 deficiency. Some could have many, or some could have none. But let's get to neuropeptides. So this is really important, underappreciated in treatment of ADHD. So the protein in dairy is casein. One of the byproducts is a peptide called casomorphin. Same for gluten. It is digested with acid in the stomach, pancreatic enzymes to break down to these smaller peptides. And there's an enzyme called DPP4 that breaks down these two neuropeptides into the isolated individual amino acids, get absorbed, and we build our protein. But what happens if we don't break down casomorphin and gliadorphin? Well, a lot happens. These are neuroactive peptides. What do they sound like? Casomorphin. They are morphine analogs, gliadorphin. They're biochemically similar to the opioids, and we've been looking at this since the 1990s. In animal studies, if we inject casomorphin into rats, they have very altered, disturbed behavior. And how do we know it affects the opiate receptors? Because we can use an opiate blocker, something like naltrexone. So if we inject these animals with naltrexone, and then we inject them with casomorphin and gliadorphin, they do not have the altered behavior. So it is quite clear that casomorphin and gliadorphin are neuroactive peptides. The original literature was primarily with autism, and that's where in the early 2000s, I was testing casomorphin in just kids with autism. And then I actually did it by accident. We checked the wrong box, and we had a very severe OCD girl who had very, very high levels of casomorphin. And we started seeing this across a whole host of neuropsychiatric disorders in children, and there's a subset with ADHD. So let's try to understand this a little in more detail. Casein from milk or cheese, digestive enzymes in the intestine. We get this neuroactive peptide casomorphin, that 7 amino acid peptide I just showed you. If you have adequate DP4, and I'll go over what DPP4 is, but for now you can see it as a zinc-dependent enzyme. It breaks down the casomorphin into the harmless amino acids. If we don't have adequate DPP4, the casomorphin enters the brain and alters behavior. Here's a summary of the DPP4, which is an enzyme that sits inside the intestine and breaks down the casomorphin gliadorphin. This is a slide that Dr. Shaw from Great Plains Laboratory developed, talking about why somebody might have inadequate DPP4. So the straws that broke the DPP4's back. The one that's not here, the bottom one, is zinc. So as a zinc-dependent enzyme, without adequate zinc, we'll talk about in one of the future modules, let's say due to elevated copper, we're going to have less ability to make DPP4. Interferon and gelatin from vaccine, antibiotic use, just the overconsumption of wheat and milk. We don't have the digestive ability to tolerate these gallons of milk or these large quantities of dairy many of these kids are eating, candida, and then we see the mercury and the heavy metals and pesticides. So it's all the things that we have good research demonstrating association with ADHD, and here's one of the links, inadequate DPP4, and we see elevations of these two neuropeptides, casomorphin and gliadorphin. I've been doing this test for over 20 years now. There's a very good reference range, and it's these ratios that we're looking at. If you see here, the 0.56 is the reference range. I begin to see pretty significant symptoms, although it varies over 0.6 up to 0.1. But you see here, this patient with a 3.68 patient-relative ratio, which is very high, and it is very likely that there's significant psychiatric symptoms due to the consumption of casein in or dairy. We need to look at all the different sources of casein in dairy, and how can we tell if someone might be more susceptible. Overconsumption of the dairy and wheat foods that I talked about, intense obsessions or intrusive thoughts are common. So we have ADHD kids that are very perceptive and obsessive and sometimes very agitated. The cravings of the dairy and wheat, the kids that can't get through a day without the glass of milk or the piece of cheese, the kids that get angry and irritable. And I use the word kids, but it's just as common with adults. And then like morphine, we have these kind of variability of symptoms. If you inject morphine into individuals, you're going to get somebody who's going to get a headache, a stomach ache, someone's going to get sedated, feel relaxed, someone's going to get agitated. The same kind of variation we see with casomorphin and gliadorphin. And we've had patients with the varying symptoms of both self-injury, rage, and extremely inattentive, the space cadets, as we call them, no symptoms of hyperactivity, and eliminating dairy has been the answer to their ADHD. So I kind of use the slide mastering balance is just, to me, a very powerful expression of all the work that we're trying to do to summarize a section so it really makes sense. So for the neuroactive peptides that I just discussed, the laboratory testing is a simple urine test. It can be part of an organic acid or done on its own. It is looking at these two, casomorphin and gliadorphin. They're called exorphins, and there are others in their laboratories, international laboratories, that are testing for more, and they might be brought over to the United States where we can test for 5, 6, or 7 neuroactive peptides. The supplementation, what do? Well, one is we try to eliminate the source of the problem, which is gluten or casein. Depending on the family dynamics, depending on the child and the age, oftentimes it's impossible. Parents do their best, they need to choose their battles, but this is how we can individualize treatment. If the casomorphin and gliadorphin is normal, and we'll get through the food allergy soon, then we can say that eliminating dairy and wheat might not be an intervention for this child with ADHD. But the most important thing probably is understanding how to supplement with DPP4 enzyme. It is offered by many companies. You have to read the labels. You don't want just a digestive enzyme. You want a digestive enzyme that has DPP4. This is a capsule and that can be opened for the younger kids that can't swallow capsules and mixed with applesauce. Side effects. The only side effect I have seen, and I've seen it enough to really appreciate it, is like withdrawing morphine or heroin or other opiates from our patients. Withdrawing dairy or gluten for some of these patients will create a withdrawal syndrome. So I've been doing this long enough to recommend parents not go home that night and eliminate all casein from the diet, particularly if the levels are really high. I recommend taking a few weeks of cutting it back and then trying to eliminate casein from the diet. Other than withdrawal, that irritability, that agitation, and those cravings, there's absolutely no side effects that I've seen with DPP-4 supplements. They should be taken 3 times a day with all meals. Common question we get asked is, well, if I've eliminated casein completely, do I still need to give the child or the adult DPP-4 supplements? And my recommendation is absolutely yes. There's casein in our vitamin pills, there's casein added to many foods that we're not aware of, and there's also health products like soy that can sometimes break down to some of these same neuroactive peptides or similar properties. So I'm recommending, at least for the first month, DPP-4 enzymes as casein is eliminated. So the right food may be the wrong food. Celiac disease is one of the more common things we're finding with adults with ADHD. These are both a study looking at kids and adults 7 to 42. 10 out of 67 tested positive. Gluten-free diet produced significant symptomatic improvement. We know that undiagnosed celiac disease is quite common. 83% of Americans are undiagnosed or misdiagnosed. And why is this so important, and why do we see it all the time? And why would I say it has to be the first thing you think about for a young adult, college age, or an adult with a presentation of ADHD-like symptoms without a childhood history? And because of our whole thesis for understanding ADHD by an orthomolecular approach is understanding that it's this malnutrition interfering with neurotransmitter synthesis, digestion, enzyme function that creates many of the symptoms that we're calling ADHD. And what is celiac disease? It is an autoimmune disorder that destroys our ability to absorb nutrients. So we see this major, rapid deficiency in both fat-soluble vitamins, minerals, and amino acids. So we develop symptoms. We have symptoms of depression, anxiety, fatigue, even increased risk of suicide. But ADHD is common. And I have a number of kids, college-age kids. They were great students, went off to college, started doing really poorly. One kid was put on high doses of amphetamines, went to the school psychiatrist, was so hyped up, they put him on Xanax to balance the amphetamines. Parents, when they found out, brought him home, and we did just our routine blood testing, and he was ate meat, ate a decent diet, but he was deficient in zinc, B12, and amino acids. So we did celiac testing, and he had celiac disease. His symptoms of celiac disease created poor attention, and then diagnosed ADHD and treated inappropriately with an amphetamine rather than treating the celiac disease. It's important to understand that some of the supplements response can be slow. One study looking at zinc repletion, it took almost a year, even though the patients were gluten-free. So we removed the offending source. So there wasn't this autoimmune destruction of the intestinal villi. So absorption improved, but some of the nutritional deficiencies persisted for up to a year. And now we're getting a lot of good research on non-celiac gluten sensitivity. They don't meet criteria. They don't have celiac disease, but they have both GI symptoms, they have immune symptoms, and I can share with you a number of patients that also have neuropsychiatric symptoms as well. So the other kind of food issue that we want to talk about is food allergies. And there are different kind of food allergies. There are IgE food allergies, and our kids with ADHD are 7 times more likely to have food allergy, so it's common. These are the foods most common, and as you see here, a number of studies looking at food allergies in ADHD. We haven't really understood the association. Most allergists will not make an association, and these are these IgE immediate hypersensitivity reactions. They are not a major part of what I would look at in my practice, because the symptoms also have physical manifestations from hives to swelling to asthma, where patients and families can understand. What we're most worried about, or in terms of ADHD, is what's called delayed hypersensitivity reactions, the IgG food allergies. And this is a very powerful tool, particularly for our young kids meaning under 12, and for those under 6, it is often the primary source of some of the ADHD behaviors. I ask people about some of my mentors and heroes like Linus Pauling and Doris Rapp, and most people nowadays do not know some of these greats in the field of integrated orthomolecular medicine. But Doris Rapp, she was an allergist. She wrote a number of books, and she was at a number of videos, and she had a number of TV shows where she was able to demonstrate and show videos of kids with food allergies, and really helped push the field at the time. Most pediatricians discounted her work, although many of us thought her work was both brilliant and well documented. The symptoms of our delayed food allergy, again, can be varied. We see a lot of hyperactive, inattentive, classic ADHD symptoms, but you can also have some more disorganized, agitated, high-strung behaviors that we see in these young kids. There are some physical signs. The most common are the red ears or the red cheeks. You often see a child who come in and say, my ear is hot. Sometimes they don't have a hot sensation, but you can see that part of their earlobe is red. This is very common in food allergies. It could be half an ear, a whole ear, one ear. We also see the cheeks. The only picture I could find is an infant, but we also see it in toddlers and adolescents as well. So slight redness after eating. Some of the other classic food allergy symptoms you can see, from bad breath to foot odors. Usually there's a history of allergies, colic, and eczema being the most common. There is a simple test that we used to do all the time called the pulse test. If your child is old enough, one of the things that you'll notice, if someone has an allergy to food, usually your pulse goes up maybe 5, the most 10 beats per minute after eating, but sometimes they can increase 20 and 30 after eating a food that someone is allergic to. Sometimes parents can engage and help. So IgG food allergies, for years before we had good testing, we asked families to do what's called the elimination diet. And there's lots of books and articles on elimination diets. I think at this point, it's a little complicated for many families, particularly with lots of other children, but essentially you're having a very limited diet, just a couple vegetables, a couple meats, and then you're slowly adding foods back and looking for behaviors that might be similar to the ADHD behaviors of that child. Here, a study done in 2011 from Lancet, 78% significantly improved as they limited those diets. And then as you started reintroducing foods one at a time, 63%, you could demonstrate the behavioral relapse after reintroducing those foods. Again, I don't recommend in my office an elimination diet. Some parents have tried it. I believe now there's just good testing. Here's just two other studies, again, older studies, 85 and 209, looking at this concept of elimination diets and then reintroducing the foods, but limited food choices, better behavior. So food allergy, I want to just get to the Feingold diet. Again, Ben Feingold was an allergist in the late 70s, and talking about red dyes in particular, synthetic dyes causing an adverse reaction in young children. He saw it, he wrote about it, and we've all seen kids with their Hawaiian punch, and I'll never forget some of my Hawaiian punch memories opening an office in the early 1990s where we watched kids just run around the office uncontrollable after drinking Hawaiian punch. There were a number of studies done. Parents really forced the hands of a pediatrician, the medical community, to do more research. When it was done early on, there was not a robust response for food additives with children with ADHD. These were kind of larger studies looking at hundreds of kids, and what the researchers found when they do a generalized study, that there was not a statistically significant difference with those kids with increased hyperactive behavior with adding these food dyes and food additives. But as we look more carefully at those studies, every one of those studies had kids that had major disruptive behavior after ingesting these dyes, and these were double-blind placebo-controlled trials. So what happened over the 20 years since some of these original studies, starting in 2007 with this study, and there were a couple in the Lancet, that we started seeing increased hyperactivity in some of these kids. These are 3 and 8-year-old, 9. And then we started looking at other food additives, and as we eliminated that, we saw more improvement in behavior. And then we started putting all the studies together, and it's that small subset of kids with ADHD. So it's not every child with ADHD. So back to this theme of biochemical individuality, it's a subset. But I used to have a slide when I gave these talks in the 1990s to parents, and the slide said, your child is not a statistic, because many of the pediatricians talking to parents just read the study that is not statistically significant in some of the early studies, but your child could be that 8 to 10% who respond and have dramatic changes in ingesting food dyes and food additives. And the work gets more interesting as we began to look at the genetic differences. And we can see that genetics play a role to the extent that food additives exacerbate ADHD behavior. And we will talk about genetic testing. It's an important part of my practice. We don't have this genetic test to help understand it, but we do in research understand some of the genetic differences. So there's a gene that supports the breakdown of histamine, histamine N-methyltransferase, and children with specific variations of this gene have much stronger behavioral reactions to artificial colors. Again, biochemical individuality. We can't test for this gene easily, but for any child under 12, I really would encourage parents to try a Feingold-like diet. Try to eliminate as many of the additives and dyes as we can. People usually see a difference quickly, but 1 to 3 months, you would notice a difference, or show parents that they don't have to be as strict. I certainly don't recommend anybody drinking the red dye in Hawaiian punch, but the strictness of the program, I think, can be lessened after 3 months. So biochemical individuality. Celiac disease. It should be tested for any adult with ADHD. Rapid nutritional deficiencies. Testing is important. Amino acids like tryptophan is often deficient. Zinc is often deficient. Folate is often deficient. And B12 is often deficient. All things we'll be talking about in relationship to neurotransmitter. Food allergies. You can look at elimination diets. There's many, many books out there. My preference is to look at IgG testing. The testing over the years have been really much better and much more accurate. I use it as a guide to begin, the process of helping parents kind of begin to choose a dietary recommendation. And then the fine gold, the dyes and additives, I hope we can eliminate those from our kids' diet as much as we can. As much as we're worried about our pets' diet, our dog foods, don't have dyes and additives now, and hopefully our foods for our children can do the same. So simple to test, but really, really important to understand. So I want to digress for a little bit. Besides eliminating the food for the food allergies, what else can we do? And one of my kind of phytochemicals that I talk a lot about throughout our ADHD course are what we call the OPCs. And I'll only pronounce it once, the oligomeric proanthocyanidins. So OPCs for short, and these are the polyphenols produced by plants to protect them. But they're the colors, the blue and blueberry, the red and the grapes, green tea and dark chocolate, red wine. Some of the original OPCs were found in peanut skins. Pycnogenol is pine bark, and pycnogenol is probably the most researched OPC that we have for our ADHD children. So I bring it up here. This just talks a little bit about the history and when it was discovered in the 1500s, when the pine bark, the tea from the needles of these pine barks was enough to help cure scurvy from the Jacques Cartier. In the 1947, Masquelier in France actually isolated OPCs. But I use it here as kind of one of our tools when we have our children with really dramatic food allergies. What do? So we try to eliminate the food, and oftentimes we get behavior. But I still find these are kids with genetically poor breakdown of histamine. They likely have other kind of immunological problems, eczema, other allergies. So I kind of use my trusty OPC and vitamin C to really support the function to help. So OPCs actually work as antihistamines. OPCs inhibit histidine decarboxylase, so we can decrease the production of histamine. And vitamin C, one of our kind of orthomolecular nutrients that we'll talk a lot about throughout these courses, has many functions, but certainly acting as an antihistamine, oxidative stress, critical for dopamine, norepinephrine synthesis and release, and nerve cell integrity. And here's some further graphics. But besides the food allergies, we actually have research looking at oxidative stress and ADHD. And any of our markers for oxidation, ADHD patients had significantly higher markers of oxidative damage and oxidative stress in ADHD. So these are very well known studies. So we eliminate the foods as best we can. We treat with DPP4 if it's a casomorphin, and we also utilize OPCs and vitamin C as best we can. The forms of OPCs I like the best, are kind of pine bark, grapeseed, blueberry extracts are the most common, as is green tea. So let's get to the next section of the course that's so fascinating and has such important relevance to our kids with ADHD, all our kids with neuropsychiatric illness, and that's the microbiome and how the gut affects the brain. When we talk about the gut and the bacteria around the body, we can kind of think about 90% of the cells in the human body are not human. They're composed of microbes and bacteria, and the microbiome is kind of the collection of that genetic material. And when we talk about genetic material of the gut, it's really staggering to think that there are approximately 22,000 human genes and over 3.3 million bacterial genes. Okay? So essentially, we are more bacteria than human. Back to this concept of biochemical individuality. No two individuals have the same microbiome. The microbiome changes daily. Many things affect the microbiome. We'll talk about it. But it's individually unique. Even twins have different microbiomes. And they're constantly changing. And we now have very good research across many neuropsychiatric illnesses that the gut microbiota affects the nervous system. So let's kind of review some terms. The microbiome I described as the genetic material of the microorganisms. Probiotics are bacteria that we would take for beneficial qualities. Prebiotics are just as important. And these are non-digestible food ingredients that promote the growth of beneficial bacteria. Sometimes can eliminate some of the pathological bacteria. And then my favorite one that's not here is psychobiotics, nutrients that affect the central nervous system. So a term psychobiotics, and a new book came out called Psychobiotics. And factors that decrease good bacteria. These are many of the lifestyle things we're worried about: poor nutrition, infections, stress, antibiotics. But I think the overwhelming, most powerful factor that affects bacteria is diet. So poor diet affects bacteria. Nutritional deficiencies affect the bacteria. The one that is probably the most common for our ADHD kids would be the use of antibiotics. We'll talk a little more about that when we get to candida and yeast. But you can see here there are multiple factors that can affect it. I don't have up here C-sections. The C-sections really start our children off with inadequate microbiome, and it's going to take a lot of work to develop it. They start accumulating bacteria through the vagina from birth and just continually to build that bacteria that can accumulate up to 4 to 5 pounds. Think about it for a minute. Anybody that lifts weights or can have a sense of what 4 to 5 pounds of bacteria are like, it is sufficient quality to make a major dent in how our GI tract functions. So, in terms of neurotransmitters, we have good research looking at neurotransmitter effects of probiotics. So we've seen changes in serotonin, dopamine, norepinephrine, and GABA based on changes in the neurotransmitters. Some of the specifics that we're most interested with ADHD is an increase in dopamine. We have research just looking at probiotics in ADHD. These were not looking at specific gut bacteria. This is just giving mothers lactobacillus rhamnosus, which is culturelle, 4 weeks before delivery and then 6 months. And 13-year follow-up was huge. 70% of the untreated kids were diagnosed with ADHD versus 0% on probiotics. 17% versus 0%, pretty significant. I don't think this got a lot of press in the pediatric community. I don't see many pediatricians talking about it, even though it's published in a pediatric research journal. And then you see the children with ADHD had fewer probiotic species at 3, 6, 18, and 24 months. And this is very common across many neuropsychiatric illnesses and, frankly, other illnesses, including obesity and a field I spent a lot of time treating, anorexia nervosa. This concept of limited diversity, I think it's quite clear from the literature that the more diverse the microbiome is, the healthier an individual. Most states that have been studied, we have good research on obesity, less diverse bacteria, anorexia, dramatically less diverse bacteria, and ADHD, fewer probiotic species at 3, 6, 18, and 24 months. This is a fun study because here a lactobacillus strain compared with 5 to 15 milligrams of Ritalin, short-acting Ritalin given 3 times a day for 4 weeks. And these were young kids, 7 to 12. Children showed improvements in attention and self-control, again, compared to Ritalin. So the general concept of probiotics are very well established. It's a truly, I believe, a revolutionary field in psychiatry now, partly because there's so much research going on. As a psychiatrist, I treat everything from OCD, anxiety, to even major psychotic illnesses by understanding, looking at the microbiome. With our ADHD kids, we have 2 kind of distinct populations or illnesses that we can understand, and that's one is Candida, and the other is Clostridia. So I want to make sure I have time to go through that. Another legendary in the field with Doris Rapp and Linus Pauling is Bill Crook, and he wrote about the yeast connection. He was a pediatrician. We're seeing so many ADHD kids, and started realizing that many of these kids had taken antibiotics, and he started treating these kids with nystatin and yeast and changing their diet with dramatic improvement in ADHD symptoms. When I started my practice in the 90s, I saw a lot of yeast affecting ADHD, even though it was not the norm, and pediatricians certainly did not support it. I believe part of the reason I'm seeing it less is less ear infections being treated with antibiotics, because we do have a positive correlation between antibiotic use and Candida. The symptoms sometimes are classic ADHD in terms of hyperactivity and impulse control, but then you also have some inappropriate behaviors. Sometimes there's cravings for sugar and grains. There's sometimes silly behaviors, skin problems, memory problems, spacey, a whole host of problems that we see both in adults and kids. Both the food allergies and the Candida contributes to this concept of leaky gut. I'm not going to go into that now, but once the destruction of the intestine starts, we start to get further absorption of yeast, of environmental toxins, of partially digested food to create more food allergies, and we get this very vicious cycle of further and further destruction of the intestinal barrier due to yeast. This was one of the older studies. Again, number of ear infections, presence and severity of hyperactive behavior. 94% of ADHD kids with learning difficulties had a history of 3 or more ear infections in early childhood. 69% had 10 or more. That's pretty close to what I've been seeing in my practice for many years. I believe it has decreased. The number of antibiotics have decreased, but it's hard to predict. When parents say, my child hasn't had many ear infections, the child might have had 1 or 2. And I can't predict that kids that have had 10 courses of antibiotics and they don't test positive for Candida, and I've had kids that had 1 course of antibiotics and they do. So testing is really important. We can look at many metabolites of yeast. Some of these we can pick up on organic acid, some of these we can pick up on stool, and then we can develop a treatment plan. I use antifungals, nystatin more commonly, diflucan when we need it, and then many of the herbal antifungals can help as well. Dietary changes are important. Limiting refined sugar. For some of the children, it's much harder. The last section of dysbiosis that I want to get to is understanding the role of a Clostridia metabolite called HPHPA. And I've been talking about this for almost 15 years. I believe that this is one test that should be done on every psychiatric impaired child or adult. It is very simple to test and has profound implications for our patients. The punchline, and we'll get to the details, is high HPHPA. Don't make me pronounce it. A metabolite of Clostridia has significant neurochemical and behavioral and neuropsychiatric effects. How do we know? Well, we know because this chemical, HPHPA, which is produced by some of the strains, we have, I don't know, approximately 100 strains of Clostridia in the gut. And there's some of these strains that produce HPHPA. And what you see here in this schematic is HPHPA with that red circle inhibits dopamine beta hydroxylase. Let's see if I have my red arrow. No, it should be a red arrow under that red circle, but you see that. So what happens? The conversion of dopamine to norepinephrine, the natural synthesis of dopamine to norepinephrine, gets inhibited and prevented. So we get this buildup of dopamine. So I need to kind of visualize that dopamine on the left side of your screen that's bigger and bigger. And our patients get agitated and anxious and can even get delusional and psychotic. Again, we see it across, just like the casomorphin and the gliadorphin, we see it across all major psychiatric illnesses. The mechanism is quite simple. We have this inhibition of the conversion of dopamine to norepinephrine. We need norepinephrine and epinephrine. Now, this buildup of dopamine, as we build up of dopamine, depending on your genetics, how quickly you break down dopamine, your COMT genes, your receptors of dopamine, you invariably get increased agitation, anxiety, hyperactivity. Again, seen it across diagnoses. It is a pretty simple test. Here you see the Clostridial markers on organic acid, HPHPA. We've seen numbers 2, 3, 4, 800, 1,000. And it's pretty clear that the higher the number, the more significant this inhibition is and the buildup of dopamine. Again, I believe that this should be a test that is completed on every patient presenting for an evaluation for psychiatric illness. I hope it happens in my lifetime as a practicing psychiatrist. Right now, it is in our kind of integrated orthomolecular circles, but we have to try to get this mainstream. Why is it so important? Because we have an objective test where if it's positive, we can make a major intervention in a child's trajectory towards major impairment due to high, and usually these are severe ADHD symptoms, to a completely normal course. How do we treat HPHPA? I use very high dose probiotics at first. Again, we're trying to displace this Clostridia with good bacteria. We look at high dose, and I kind of randomly have started using up to 200 billion CFUs per day for a couple months. Controversies when to take probiotics. I'm not sure it really matters. but I usually recommend after meals. Oftentimes, particularly for the younger kids, we're able to retest the HP-HPA and see a fairly dramatic decrease in behaviors. I share with parents and clinicians that I work with that nobody feels well with an elevated HP-HPA. So it's just a simple, elegant marker. As it decreases, patients feel better. I have tested, repeat tested in 2 or 3 months, elevated HPA with the probiotics, and we have not seen significant difference. The symptoms are severe, either in adults or children, and then we use antibiotics. So for an integrative psychiatrist to talk about antibiotics for the treatment of neuropsychiatric illness, you know times are changing, and you also know that it must be really significant, because I'm quite careful of practicing out of my scope as a psychiatrist. But severe neuropsychiatric symptoms, elevated HPA, non-responsive to high-dose probiotics, I use vancomycin or Flagyl, antibiotics that destroy the Clostridia that is causing the metabolite HP-HPA. How do we use HP-HPA and the vancomycin? Years ago, we would just use 10-day courses, and we saw kind of this improvement in symptoms, and then symptoms came back months later, sometimes sooner. So now there's kind of a 30-day pulse cycle that we're recommending for the treatment of HP-HPA metabolites of Clostridia. Vancomycin I found has been the most effective, so I use vancomycin more often than I use Flagyl. I have not used this on young kids under 12 because I have gotten the positive response to the probiotics, but for adolescents and adults, seen pretty dramatic decrease in spacey symptoms, aggressive symptoms, contributing to the HP-HPA. So I continue probiotics. I cut down the dose a little to just save on cost, but we're still using high-dose probiotic. And then it's day 1, the vancomycin, 3 or 4 times a day, and then 2 days without the antibiotic, and then day 4 using the antibiotic again, 3 to 4 times a day. It's kind of this pulse, 1 day on, 2 days off, for the treatment of HP-HPA. So I think I hit most of my summary for dysbiosis. I'll try to just share a little bit again here. Dysbiosis, very common problem we see in ADHD. Laboratory testing usually involves organic acid, looking at microbial metabolites. We have microbial metabolites of yeast and microbial metabolites of bacteria, certainly HP-HPA. Supplementation, over the years, I've been getting much better results with higher dose of probiotics. I try to recommend twice a day, again using 200, 300 billion CFUs. I use multi-strain supplements. As much as now people are marketing these single strain supplements, I believe it's hype. There was one study that was done. They happened to use that strain and they got better. But there are also studies looking at if you supplement with one strain, you also start developing rapid growth of additional strains. So I believe the combination of dietary changes, prebiotics, and multi-strain probiotics, we can begin to start healing the gut. I do not recommend someone take the same multi-strain probiotic forever. I believe the science is not sufficient enough. So I, over the last few years, been recommending every 2 or 3 months. There's no science, but if you're using this probiotic with these 4 strains, why don't you switch next 3 months to a different high dense probiotic? Again, diversity appears to be the key to health across major illnesses, medical as well as neuropsychiatric. Side effects. I've had some individuals who've had GI complaints with probiotics, not common, but often, sometimes. I've often, not often, I was going to say I rarely have agitation from taking probiotics. Sometimes we can, if someone's not doing the testing, if you use probiotics and someone has candida, before you treat the candida, that we can get an exacerbation of symptoms. So with candida, I use Saccharomyces boulardii. I don't use a multi-strain probiotic. And then I would use my antifungals, and I would be doing that for a couple months before I'd be introducing multi-strain probiotics. Very few side effects to worry about. Dysbiosis. So, tonight we talked about a couple parts of the plus-minus plan. We talked about food and food allergies. We talked about neuroactive peptides, importance of celiac disease, importance of understanding the food allergies, the importance of looking at overgrowth of yeast and Clostridia, particularly DHA metabolites, HPA metabolites, sorry. So now I just want to take a step back as we kind of close and open the floor for questions. That I am focused on this entire course on kind of the biological treatments, but we can affect our kind of non-medical interventions, exercise being critical, as well as mindfulness. And we never think of mindfulness in terms of ADHD, where we're talking about hyperactive adults and kids, but we have actually good research on mindfulness in ADHD. This is a study done in 2012, 11 to 15-year-old boys, conducted 8 weekly group sessions, decrease in some of the ADHD behaviors, and helpful for parents. And this is another study, 8 weeks of mindfulness training in adults, 78% reduction in total ADHD symptoms, and no report of depression. Again, we think of anxiety, we think of depression with some of the newer research, but there's some great literature and helpfulness for ADHD. Oftentimes, I'm not asking a child to sit quietly for mindful meditation. Usually the walking mindfulness approaches can be most helpful, as these kids might have a difficult time sitting still. All the mindfulness exercises can be done while they're moving and being aware of their surroundings. This is the book that we talked about, Finally Focused, and we're going slowly dissecting that over the next few seminars. So I want to thank you, and appreciate you being with us tonight. Thanks again.